Great. So we're recording. Hello, everybody. Welcome to ANG's 2020 clinical life as a clinical nursing student panel. Welcome, Angela. Thanks for coming and joining us. So today, my name is Bianca. I happen to be the president of ANGS, and I help put this event together. And on our panel today, we have Stephanie and Melissa and Megan and Belinda and Angela. We're all MSN students. I'll have them introduce themselves and talk about what program they're in, whether or not they're working, and who their previous clinical professors were, just so if you guys have the same professor, you'll know kind of who to ask. Like Megan and I had Herrera, so if you have Herrera, she has a very specific kind of way that she likes us to work, and so it'll be good to know who our previous clinical professors were so you can kind of pick our brains. But this will be focused on clinical stuff. If you want to ask how clinical is applied to our current jobs now, we can talk about that as well. But I just want you guys to feel confident and comfortable going forward into your clinicals, because it's not as daunting as it seems. And thinking back retrospectively, it's kind of like, I can't believe I was as stressed out as I was. So I'm hoping this can calm some of your nerves down. Again, this is being recorded, so we'll be able to share this with anyone that's coming in later or anyone that isn't able to join the meeting right now. We'll be posting this, and I can share this video with you guys. So we'll start with Stephanie introducing yourself, and we'll kind of go down the line, and then you guys can ask questions. And if you don't have questions, I have a few questions I can have them answer as well. So,
hello, I'm Stephanie. I am in my first semester of my master's in the CNS program. I had Katie Castillo for my first semester in the AE foundation year, and then my second semester I had Dr. Lynn, so two different instructors, both awesome. I am currently working on the orthopedic floor at Seton Medical Center on 6 North, and that's a little bit about me. Thanks for having me, Bianca.
You're welcome. I feel like a newscaster. Now over to Melissa and her introduction.
So my name is Melissa, and also like Stephanie, I'm in my first semester of my MSN program, and I'm part of the LEADS program. And I currently work in Meridell, which is a residential psychiatric facility for children and adolescents. It's located at Liberty Hill, Texas. And for both of my semesters in the fall and in the spring, I had Dr. Lynn.
Thank you. And how about Megan?
Hi, everybody. My name's Megan. I'm currently in my first semester of the CNS master's program. And for both semesters of adult health clinical, I had Professor April Herrera. Currently, I am also working with Stephanie over on 6 North at Seton, Maine on the orthopedics unit. Thanks.
Awesome. And how about Angela?
Hello. I am also like everyone else here with my cohort. I'm in my first semester after the foundation year. I work at Meridell Achievement Center, and I was with Melissa, and like half of our cohort got hired there. There's a lot of us there. I'm in the pediatric nurse practitioner program, but I was originally LEADS. I did the unilateral transfer at the end of last year into the peds nurse practitioner program. And if you have any questions about that, I can answer. And my first semester, I don't know if she's teaching, I don't think she's teaching AE, but I had Dr. Hendrickson. And then my second semester, I had Dr. Lynn.
Great, thank you. And Belinda?
Hey everybody, my name is Belinda. I am in the CNS track, and as everyone else, I'm in the first semester of the master's portion of the program. And for both semesters in the foundation year, I had Dr. Lynn as my clinical instructor.
Awesome. So I want to start off with, sorry, there's traffic, but I don't know if y'all are hearing all of that. I'd like to first ask all of you, we can go in the same order we went in if y'all remember. If not, I just pitch in, or if you don't have something to say, you can pass. But how you got comfortable with doing physical assessments and knowing whether or not you're hearing the right things, or if you're doing the right assessment, because it'll be some of the first times these students are meeting patients and doing physical assessments. And it can be kind of intimidating, especially because it's one of their first times. So I'd like to hear how y'all transition from Johnny Odell to a real person.
Okay, so for me, what worked for me was I listened to my peers' lung sounds because they're healthy. So once you know what the healthy lung sounds like, and like a normal heart and like and bowel sounds, then when you go to clinical, I know for my first week, either I did it with my clinical instructor or the nurse that I was paired with, and I just watched them do an assessment the first time, and then that kind of helps me get comfortable. So I'm a very visual learner. So for me, getting my clinical instructor or even have them walk me through it, that's okay. Like me putting on the stethoscope and listening, and just, maybe having them listen at the same time and just together be like, okay, are we hearing the same thing? Like, this is what I'm hearing. And also, if you hear something and you feel like something is off, it's always nice to get your instructor or your nurse's second opinion. So just verify with them and be like, hey, I heard some wheezing. Do you mind going with me and verifying that? And they'll most likely say yes. And that's what worked for me. I second guessed myself a lot at the beginning of the program. So just having that constant reassurance was really helpful. So having, relying on your instructor is okay, and getting the nurse you're paired with to join in too, that's okay too.
So same as Stephanie, pretty much it's for physical assessment, it's a trial and error basis. So it's until like you pretty much get comfortable with it. And I guess like if it's like the first time you're doing a physical assessment, just be comfortable with the patient, get to know them, have like a nice conversation with them, and just be sure that you're always like telling them, it's like, well, now I'm going to listen to your lungs, I'm going to listen to your heart. Is it okay if I remove the sheets to like look at your feet? Just like be like, to me, like being very proper with them, that kind of helped me like feel comfortable and also make them feel comfortable at the same time. And yeah, like also like, I mean, pretty much Stephanie hit like all the points. Get your instructor involved if you're not sure about something, especially with Dr. Lynn. She won't hesitate in going with you and just like doing the whole physical assessment with you. That way, like you feel more comfortable. So yeah, like if you have Dr. Lynn, just ask her as many questions as you would like, and never be like afraid to approach her or be intimidated by her. So.
Going off of what Melissa and Stephanie said, all those are great points. And another point I want to make is just make sure you don't just do the physical assessment, make sure you're asking your patient questions. So when you're listening to their heart, ask them if they're having chest pain. When you're listening to their lungs, make sure you say, are you feeling shortness of breath? Are you dizzy? When you're doing that strength test, you need to be saying, are you having any numbness or tingling in your arms or your legs? Make sure you ask those questions too, because part of the physical assessment is something that you actually may not be able to see, but your patient is feeling. Another good one is nausea and vomiting, and when was their last bowel movement, because all those things are going to come up when you're giving a report.
Do you have anything to add, Angela?
Yeah, ditto what everyone else said. I found all the instructors I dealt with are more than happy. Dr. Lynn loves to go over things with you. So if you have her, the more you ask, the better, the more questions you ask, because she loves questions. A lot of them, really, they're professors because they love teaching. And so they actually really like if you have an abnormal finding, if you ask them. Surprisingly, a lot of times students find things in clinical because we maybe only have one patient or two patients. So it's less. And so you're able to really like go over things more thoroughly. Like for instance, my, I think, second semester in adult health before we got kicked out of the hospitals, I had a patient that hadn't been having bowel sounds because she had like major intestinal surgery, and it had been like days. And I was like, and everyone's like, no bowel sounds. They were all charting that. And then I listened, you know, because it's supposed to be like, you're supposed to listen up to 5 minutes if you're not hearing anything. But I don't know, nurses are in a huge hurry when because they have 4 or 5 patients. I don't know how long they were listening, but I was able to hear bowel sounds. So I'm like, oh, is this just like my stethoscope moving? Like, I don't know. I was really like worried that it was just me. So of course I like asked my instructor, can you listen? I don't want to tell this girl I'm hearing bowel sounds. Cause she was a young gal. She was super like knowledgeable about her surgery and everything. And the instructor listened, and sure enough, there was bowel sounds, which we were able to then contact the doctor and let them know, because that was a really good sign. So you'd be surprised like what you actually already know as a student. I think that's probably the biggest thing I would say. And you have more time to go over things in more depth, and you have an instructor there who's so knowledgeable. So definitely utilize them.
Hey, so I think for me, just helping me keep track of getting everything in the physical assessment. Again, I loved going to open lab and practicing on your peers, because that's going to help you. Like Stephanie said, you're going to learn what normal lungs sound like. You can feel a good strong pedal pulse, because maybe some of the patients in the hospital might not have one, or it might be harder to find, but that'll give you a good baseline. But I would always, I know for Dr. Lynn, we took our brain with us. And so on the back of the brain was the full body system, everything. And so that really helped me going through there, writing things down. And also one thing, your patient does not know everything that you need to check. And so if you forget something and you're charting and oh, I didn't check that, you can always go back and check. Like that is completely okay, and that's normal. And then ask your professor, always. Dr. Lynn, I had Dr. Lynn, and like everyone said, she loved teaching and loved helping. And then for abnormal sounds, so I know there was one patient that I had with, believe he had COPD, and I was hearing something funny. It was different. It wasn't normal. And again, you know, when you're first starting, you don't always know what to listen for. But I found professor, also ask your nurse, and you know, YouTube. Hey, like that was always helpful for identifying, you know, what is rhonchi, or what is, you know, what does this sound like, and learning those kind of tricks. And you can find really good resources online, like, you know, if you're listening for crackles, like rubbing your hair by your ear, or like the plural rub and you rub your fingers. There's a lot of tips and tricks out there that'll help you learn what those sounds actually sound like.
Awesome, thank you all. And the next question I think that would be really helpful to have answered is how you juggled all of your classes and lecture in adult health with going into clinical 1 to 2 to 3 times a week and being exhausted, and what works for y'all.
So for me, I had clinical on Mondays the first semester, and then Tuesdays in the next semester. So the first semester, it was, you know, the first day of the week, and I don't know if y'all are still going in the day before and picking your patients, but no? Oh, okay. So
they're going in at 5 a.m. day of
to
gather information.
Well, that honestly, I think that's even better, because then you can like spend more time looking through their charts and just, you know, planning ahead, reading through their documents. The H&P is always helpful, kind of seeing like what the plan is for them. So balancing clinical and class, for me personally, I always took a nap after clinical, because believe it or not, whether you were standing a long time or not, but it's mentally draining, and it's really good to take a break. Breaks are important. I know the foundation year, it's like hardly any breaks and just nonstop full time. But remember, you got to take care of yourself. You can't take care of others if you don't take care of yourself. So I am heavy on the self-care. To this day, I'm still like self-care. So take a break, take a little nap, or if you're not a napper, go exercise, do something you enjoy, watch TV for an hour. I know that sounds like a long time when you have stuff to do, but honestly, like, you'll be able to focus better when you do have to move on to adult health or any of your other classes. Just make sure you take care of yourself. So that's how I managed.
So for me, I guess like at the beginning, I was like not really much of a self-care person, but like as I kind of went on, I kind of noticed it's like, you know what, like I need to like take care of myself in order for me to excel. And once I started doing that, you could totally see like a difference. I was able to retain information better. I was able to study even better. And also, like Stephanie said, naps are very important, especially after clinical, especially since like now you're like having to be there at 5 a.m. Yeah, once you're done, like have a good lunch, get a good nap, and then, you know, go back to whatever you need to do. And with classes, so what I did, since pretty much adult health took like a big chunk of like the fall semester with clinicals, I would focus on theory, adult health throughout the weekend, and I would just kind of like separate that. And if I had clinicals on Tuesday, then what I would do is that on Monday, I would do half of the lecture that I needed to do to study for Wednesday. And then on Tuesday after clinicals, I would do the other half and then review the whole thing together. So it's just pretty much setting up like a plan and a schedule. And if you needed to write it like on a piece of paper, just go ahead and do that, and then just kind of plan each day, like this day, if I don't have clinicals, I'm going to do like this class and then finish this. Or if I have clinicals, after clinicals, like this is what I'm going to do, and just kind of stick to that. And that's a good way to kind of just organize yourself and be able to kind of handle both at the same time. And also sleep, go to bed early. Like once 10 o'clock hits, that's what I did to myself. Once 10 o'clock hit at night, if I had clinicals the next day, like I would just even like force myself to sleep, because you need that sleep. And also, since you guys are not going on the day before, I think that's like better, because as a nurse, you don't have like, you know, like hours to learn about your patient. And that's what I really liked in our second semester, where we didn't have to go in the next day, because you kind of, you know, you get used to just getting like shift report on that patient and then just going from what you have, because honestly that's how a nurse works. I mean, you don't get to read the whole chart, but like, I mean, for your projects, I mean, definitely go into the charts, but start practice. Like I would kind of start practicing and like learning your patients in depth, and then kind of getting away from that and starting to kind of just try and get like shift report from the previous nurse, and just kind of going on from that to get yourself acquainted, yeah, with your patients and learning like the real lifestyle of a nurse.
Basically everything they're just saying. The only other thing I would add is make sure you're like chunking all the material, because you do with a lot of your classes, you have these writing assignments, which is not, you know, what you're going to be doing when you're on the floor as a nurse. Like, no, we never write anything except for our charts, but you will have these big 15, 20 page, like, I don't even remember what they're called because I blocked it out of my brain because I don't like thinking about it. But
concept maps.
Oh yeah, concept maps and stuff like that, and all these nursing diagnosis assignments. But like when you do them, you know, I would procrastinate till the night before, and that's how it worked for me. But I honestly don't recommend it, because I would procrastinate by doing other school stuff, like studying Swartz's PowerPoint slides like 4 times, which is unnecessary. But what I recommend is just being like, I'm gonna do the first 2 pages of my client database, and then I'm gonna read through the PowerPoint slides for Swartz's ones, and then I'm gonna listen to the lecture for maternity. And then you can go back to doing another couple pages of your CDB or self-caring, watching a TV show or something. But just make sure you chunk it up, because if you just leave it all for the last minute, you will regret it, and then you will be behind on sleep, and then you will show up to clinical and you will be tired and you won't want to be there, and you're not going to do as well as you would have hoped. It's all a chain reaction. So that's all I had to say about that.
So for me, my experience, I don't know if any of you guys who are here have kids. I know one of my mentees has 4 kids. I have 4 kids, so my self-care situation a little bit different than most, because I would go to clinical all day, come home, have to do homework, deal with my kids, do all that stuff. And then once I got them into bed, I would like work from the time they went to bed till like 1 a.m. usually. So I drank a lot of coffee. I didn't get as much sleep. To be perfectly honest, I'm like a type A person, but foundation year, especially fall, I was like, bees get degrees, and that's all we just have to worry about. Like, And that's really like real because this is like full transparency. I would come to like clinical in fall, like I had it on Mondays. I think Mondays or Tuesdays, I can't remember. And I had like the friends on my floor, I would be like, I'm quitting this program. I'm done with this program. Like, I'm so sick of this. And like, because I was like, at the time, like now it's all water under the bridge, but I was like having problems with one of the professors. And then like, has anybody here had Professor Otto yet? Like, I don't know if anyone's. So she's amazing. And I actually was on a rotation with her in the ER and like told her my whole sob story. And she's like, you know what? Because she just graduated in 2017. She's like, I had a really similar experience with a different professor. And she's like, the biggest like screw you is not dropping out. It's graduating this program and being like, now we're peers. What's up now? And like, that's so true. And it really was like a turning point for me. And I wasn't failing anything. I had good grades, but I felt like at the time, like I was being like targeted unfairly. And so it just was really hard because I, felt like it was unnecessary. So, that's like a personal story from me. And I think in fall, you really feel that because it's definitely the hardest semester, like for me. And I think probably everyone would agree, fall is hell. When you get to spring, all of a sudden it feels so much better. You don't have to deal with Professor Sports anymore. And all that stuff is like water under the bridge, and it just feels so much better. And you're like getting ready for NCLEX and everyone wants to hire you. And it's like, oh, okay, things aren't so bad anymore. But fall was bad for me. Like I legit was like, told Professor Otto, like, holiday comes and I'm done. So, but I took the NCLEX and I'm still here. So there's that. So that's just a little, if any of you are feeling like that, like one of my mentees, I have two, like text me the other day and they were like, I'm so done. Like, I'm really frustrated. I want to quit. I'm like, trust that I said that like every single Monday in my fall semester. Like, and my friend would always it was he was like, if you quit, I'm going to quit. So that's two people out of the program. So you can't quit. So I'm like, okay, I'm not going to quit just because I don't want you to quit. So anyways, that's my story. Just a little like, hype up if you guys are feeling really like stuck right now and down.
All right. So for me, trying to balance clinicals with class, I'd say I'm kind of a type A personality. And so it was difficult, but I did find a rhythm. What worked for me in the end was, like Melissa said, I had to have a schedule. I would always love to-do lists. Like I had a small group, and we would meet every single week and we'd be like, what is the to-do list for this week? What are the priorities? What do we need to do, first, second, third, fourth, fifth, and so on. So I would take that and then put things out on what days they need to be done, and then just look and see, okay, if you have a CDB, like Megan was saying, if you have all these things, like allot yourself how much time you want to spend on that project for that day. And even if it's 30 minutes or an hour, write it down, give yourself a schedule, because then if you have a schedule, you are more likely to stick to it. If you just write like, oh, well, I need to work on these 3 things today. I guarantee you, like me, especially during quarantine, when you're stuck at home, you can find a million things to do other than the things that are on your to-do list. So if you give yourself a schedule, you are more likely to stick to it. And balancing life, there's always going to be those nights where, especially if you have a CDB due that night, or if you have something big due the next day, that you're going to be up. Like it might be midnight, it might be 1 a.m, but try to minimize that as much as possible. And if you can, and I'm not sure who said it, but it's such good advice, just turn the computer off. Like once you get to a certain point, if it's 9 or 10 at night, you're probably, the quality of work that you're putting in is not going to be great. You just need to go to sleep. You need to stop it, shut the laptop, shut the computer off, and start winding down and get rest. Yeah, I would say that was sleep. Sleep, super important. Sleep when you can.
Those are great answers, you guys. Thank you so
much.
much.
Can I add something really quick?
Yes, please.
So really quick, adding to something is, don't isolate yourself. Make sure that you kind of find a group, build a group if you need to, because that's going to help you so much, especially with support and keeping up with assignments and, you know, just studying even like a study group, that's just going to be like a big thing that I noticed made a difference for me. I started by like kind of like isolating myself towards in the summer, and then like slowly I got to meet people, and then that's how like we eventually like formed a group like for studying, or even like Belinda said, like keeping up assignment lists. That was like very helpful, so I highly suggest that.
I'm so glad you added that, because I'm definitely one that I have a hard time getting into groups and studying, because I'm not the most, sometimes I like Megan has mentioned, I put things off to the very last minute. And so when I do join in groups, I'm kind of like, I'm so behind and I feel guilty about it. But having that group keeps you accountable. And so I think that's so important. And that's something I've put more effort into this semester in my MSN program. And I can tell you it's helped me a lot mentally, because we can even like bounce off each other and talk about how difficult things are. And it helps relieve stress. So I super support that. Find somebody, especially I think with this cohort, it's going to be extra difficult because most things are online, and you guys aren't seeing each other in person as often, except for clinical and skills. So finding someone that maybe you guys are willing to see each other in person and study together, or even just have like routine Zoom calls or FaceTime or whatever, I think would be very, very helpful for your mental health and to support each other in school. So for everyone that's in the group, those are the questions that I had prepared. I can come up with more if y'all don't think of any, but I'd like to go to the chat. So if you guys have any questions, go ahead and throw them in the chat. And we'll start off with, Pragati wanted to hear more about what Angela had to say. I'm not sure if it was talking about your job, and then Lisa's interested in your unilateral transfer, Angela. So if you could expand a little bit more on that, and if we have more questions in the chat for getting more specific on what they want to know, that would be helpful.
Yeah, Angela, my question was also about unilateral transfers, and not just for what you chose to do, but if there's other options out there, if you can speak to that. Thank you.
Yeah, so you guys will most likely get an email. So when there's open slots, I had like an interest in 2 different unilateral transfers. One was the PNP and the other one was transferring into the PhD. I ended up choosing the PNP just because we may be moving because we're military, so it like kept us here shorter. But there's definitely like, if you're interested in the PhD, I know that they allow like transfers from Leeds there. And then for the PNP, they send out an email like around March timeframe and let everybody know, like who's in. Tracy will let everyone know like who's interested. All you have to do is get 2 recommendations from faculty and then write a statement. And then you have to do an interview. And our year, so every year is different. Our year there ended up being 4 people chosen, but we didn't have that many apply. I think there was only 5 that I knew of that applied. And then we have 2 that have been pediatric nurses that got in. So there's 6 of us in our cohort now. But I don't know about y'all's cohort, how much interest you'll have and whatnot. And I have heard in times past, this wasn't the case for us because we didn't lose any one in the psych program, but in the past, if psych slots have opened up, they've reopened them up to the cohort to track. The track transfer is immediate, and it's 1 additional semester more than Leeds. So I have 3 more semesters. It's actually like the same amount of time as Leeds, but Leeds does all summer next semester, whereas like PNP does a traditional calendar. So we go in that spring, but where Leeds graduates in December, we go through till spring, but we don't have the summer semester, if that makes sense, because we're more traditional, because so many like outside people, I think, come into the program. So yeah, and it's been great. I love it. So there's no unilateral transfer to FNP, only because you have to have 2 years experience in nursing before you can do FNP. But I also will tell you that every class that you need for a nurse practitioner, like to get into a certification program, is given in the Leeds. You do advanced patho, advanced assessment, and advanced pharm. And those are the 3 main classes. with an MSN degree you have to have, and then you only need your clinical portion. So if you do stay in leads, you can do the clinical portion for, like, let's say you really want FNP, you could stay in leads and work during that whole time. And then as soon as you get done with the leads, apply to a program to do the certificate and then do the FNP, if that makes sense. If that's like your goal, that's probably the best way to do it, because you will get the classes in the leads, you just won't get the clinical portion of like the NP that you choose, the route you choose. Is there any other questions about that?
All right, thank you. And if you guys have any other questions about clinicals, okay, we have a few coming up. How did you all manage the emotional toll of nursing? They're on the oncology and med-surg floor, and a few of us felt pretty down after a clinical on Monday. That's a great question. So if y'all could speak up on that.
Yeah, so is it okay if I go first? Okay,
Yeah, please do.
so I think I can definitely relate in that regard. I once did a surgical ICU rotation where, for whatever reason, I got assigned to a patient who was pronounced brain dead, but the family didn't know. And it was due to assault that this patient was in the hospital from another family member, so it was very traumatic. And I had to be there when the family found out and when they went through the process of deciding if they wanted to do organ donation. And when you're a new nurse, there's not a lot you can do in that regard. So you mostly, when you go through that kind of time, you need to be there for the family, because there's not much you can do medicinally. And part of being a nurse is being caring and compassionate. So focus your energy on the family, focus your energy on doing what you can for them, and follow your nurse's lead. And then after, I did that for 6 hours, once I got to be done, and the 30 minutes before debrief, I just went to my car and I cried, and I called my mom and told her what happened. And you have to allow yourself to feel those emotions, because if you don't, you're not going to be able to move forward from it, and you're going to let it stick with you for a really, really long time. And you need to think about everything you did right. When those times are happening and you're a nursing student, there's not a lot you can do. Just think about all the things you did to try to make that person more comfortable, because it is a lot and it is an emotional toll. And, even working on the orthopedics unit where most people go for elective surgery, you still see things that hurt your heart and make it a difficult time. And you have to just have faith and trust in that what you did was the best and that you made an impact on that family. And then you have to, once you've cried it out, let your emotions out, talk to somebody, you let it go. Because if you let every single person who was dying, or you just saw something that hurt your heart, weigh on you, you'll never be able to move past it. But also, remember those lessons and experiences and use them to, keep going and better every other interaction after that. So I hope that answered part of the question.
That's a great answer. I also want to share my experience. I had a patient who came in from a car wreck, and her husband and son had passed away. But her family was there, and they were all supportive and loving, and you could tell the family was really close with each other, and they found things to laugh about. And I found that really important. And I have a resting sad face. That's what I like to tell people. And so she was like, "Why are you sad?" And I'm like, "Well, I'm not, I was obviously, but it was still it's difficult, and you don't have to put on a strong face. There's a lot of studies that show that patients really appreciate when doctors and medical personnel show emotion. It helps the patient find connection with something. And so if you're there for your patient, you do what you can and what you're able to for the patient. Like Megan said, focus on the things you can do and the things that are helpful, and your patients will really appreciate it, that you're there to help brush their teeth or rinse their mouth, and hold their hand even if their family's not there, and offer family ice and water and whatever they need. And just know that it's a very vulnerable space for the patient and family, and it's a privilege to be a part of that. And but to, again, just know that you have to feel those emotions and experience them and be able to move on from them eventually, and know that this is part of the career that we're going into, and it's part of just the school that we're in, that it's going to be really hard sometimes, but to allow yourself to feel those emotions and be able to kind of put grace on it and move forward from it. And it's okay to cry. I called my mom and I cried too afterwards, or my boyfriend, and I just was like, you know what, this happened and I'm having a hard day. And you know, if you have to have ice cream or whatever your coping mechanisms are, like really lean into that, lean into your friends, into your peers. And you talked about how a few of you felt down, and if you're there together and you can help each other through those moments, I think that'll be really important and good for your own healing process. And I'd like to say it gets easier. Sometimes it does, and sometimes it comes back and it hits like a train. And to just be prepared for that and not get too emotionally invested, to know the difference between sympathy and empathy, and just being there and knowing this is your job as a nurse, to take care of your patient and their family members. Do any of you have something else to add? Okay, so we have another question from Kathleen. What did y'all's communication look like with the nurses? Would you work alongside with them in clinical? What would you ask them, and how would you put yourself out there to get the most out of your experience?
So for me personally, as you progress through the semester, you're learning new skills. So that's one thing that I say that I'm really good at, is communication. So when you first, meet your nurse, introduce yourself, tell them you're a student, tell them where in the program you are, because our program is kind of new to certain nurses and other nurses are familiar. So just explain to them, I'm in my first semester of the AE program, which means, this is my first clinical. So just let them know what you're able to do. So for instance, we couldn't give narcotics, and I'm sure it's still like that. So just let them know, I'm unable to give them their narcotics, but I can give them all the other medications. I'm going to be doing assessment and giving meds, and then just kind of keep them updated, keep them in the loop. So let's say you did your assessment and you heard something off, then go back to them and let them know, hey, I did my assessment, this is what I found. Something sounded off, do you mind checking in with me? Or just keep them in the loop. That's, even if you go to lunch, hey, I'm gonna go grab lunch really quickly. Do you mind, keeping an eye on my patient? Because most nurses will back off, like they'll let you do everything. So it's important for you to get back to them and just keep them updated, because it is their patient at the end of the day, and you're going to leave and they are going to take care of them for the next 6 hours. So yeah, just and let them know too, be open. I've learned this skill, like I've done IVs in class, but I haven't done it on a person. So if you have that opportunity, I would love to do that. So just vocalize what you want from them.
I just want to say, like, I agree. For the most part, I found like most of the nurses that we followed were great. You're always going to have a couple that maybe aren't super into students, but the more you're willing to do, the more you'll win over your nurse. Like if you're in there cleaning your patient, being like, what can I do? Changing them, like wiping all the butts, like your nurse will like you, trust me, because a lot of times that stuff, if there's no PCT or they're busy, falls onto the nurse. So the more you can do, I found, and the more you can make yourself valuable, it makes the nurses you're working with super thankful for your help. So I think probably I only had twice where nurses, like there's this one, it's kind of like funny at Seton, who is like known to like absolutely hate students. And I like am more like, let's see if I can win her over. And like, I would like, she's like a person, if you say hi to her, she will not respond to you. And by the end, like I would try to help her so much, she finally started saying hi to me, and everyone like loved it on my floor, thought it was hilarious. But because like, I was always like, I'll wipe any butts, like I don't care, nothing's beneath you, like, and really that's true. Like just do everything that you can, help out the PCTs, help out whoever you can, make yourself valuable, because the nurses will know you on that floor and know that you're willing to do whatever, and they can count on you to help, and they'll like you for that.
I agree with Stephanie and Angela. So as far as communication goes, like what Stephanie was saying, when you get there first thing in the morning and you pick your patient or you pick your nurse, however y'all are doing that. Just communicate with them what you can and can't do. And if there's anything, I know Dr. Lynn always wanted us to have like a goal for the day. Let your nurse know, because they might know all these other things that are going on. It might not even be their patient, but if they hear of something really interesting, like the PIC nurse is going to come or someone's going to get a blood transfusion, let them know what you want to see, what you haven't seen. And also, like Angie was saying, wipe the butts, fetch the ice, like do all those things. If you are doing that, I guarantee you your nurse is going to be so grateful that you're there and helping, and you're going to see so many more cool things. Like, I know there was probably one day where I was feeding patients, doing bedpans, and not, more PCT things than nursing things, but because of that, that nurse felt so like she, was really grateful for that. And I got to see, like in Swartz's class, she calls it like the halo, like, where a patient might have a cerebrospinal fluid leak. And so she showed me that on this dressing. And once you see it, you'll always learn that. And so being able to see those kind of things, even if that's not the patient that you're assigned to, I think having a good, strong communication with your nurse, you will be able, they'll show you other stuff and explain other things, and you'll be able to find out, and get to see really cool things like, what is it? The procedure where I'm blanking, I'm sorry. It's been a long week, but you'll get to like respiratory therapists, like if they're coming in and they're doing extra procedures and the nurse knows that they're coming, you're going to be more likely, if you have a good relationship with your nurse, they will tell you what's up and you can schedule your day around that.
Thank you, guys. So I'm reading the questions, and Amanda, the question about the CNS track, we're going to have another panel coming up either in November about which graduate track is right for me. So keep an eye out for that one, and we'll be able to answer those questions. And we kind of talked about, Lisa asked about nurses who aren't exactly excited for a student to follow them around. We talked about some tips, Angela said, to help them out as much as possible, and just be friendly and find out something about them. I think a great trick is to ask them about themselves and find what they're interested in and talk about that, and then they'll maybe be the nicest nurse and the most helpful for you, and give you the most experiences.
I do want to ask one thing about that real quick,
Yeah.
if possible. So one time when I was working on the floor, I had a nurse who showed up late. When she found out she had a certain patient, started saying, oh, there's such a, like, cussing about the patient. And just overall didn't really seem like they wanted to be there. And that's like another type of nurse that you wouldn't really want to be around learning from, because they've obviously lost some passion for their job. And so I pulled my professor aside at the end of my shift and said, this is what happened, and I don't think it was a very good experience. And so she wrote that nurse's name down and just made sure that a student never got her again. I don't know if she went and talked to the charge nurse, probably not, and that's okay. Like, I don't know what's going on in this nurse's life. But I did just say I didn't think it was a very good learning experience. So you do have the power to go up to your professor and be like, I didn't enjoy working with that nurse. If possible, like, can I not work with that nurse again? But you really need to, pick and choose that wisely. I was just very unimpressed by them cussing about patients. Like, that was not okay with me. So just make sure, if you aren't learning enough or they're not letting you do things, just let your professor know your professor can step in. So just know that's always an option.
And if they're like unsafe enough and you see like really big red flags, report it. We actually had a student that had like a terrible experience with a nurse and that was doing dangerous stuff, and reported the nurse, and the nurse actually was let go. Like, not so it's important to bring that stuff up. If you see things, say something to your professor, because it's below your pay, or it's above your pay grade to say anything, but they 100% can handle it if it needs to be handled. So like, do say something if you see something.
And then just adding onto all of this, if by any chance you are bilingual, one thing that I do suggest is don't let yourself become a translator. So first, just finish your work, attend to all your patients, and if you're charting, I mean, you have time, go ahead and become a translator and, help other nurses. But yeah, first telling me, so you know what, let me first attend to my patients, finish my charting, do what I need to do, and then go ahead and do that. Because like once they know that you're bilingual, it's gonna kind of be like a little thing where it's like, oh, you know, she's bilingual, like, you know, either you get all the bilingual patients, which is okay, or you like, you know, you just don't become like a translator. Because I mean, there is translators in there for them, like they can have like all this equipment. But yeah, that's like one thing that I did learn is like, don't become the translator yourself. First, attend to your patients.
Awesome. And another thing we think would be really helpful is to share some tips. And this will be the last thing we'll kind of touch on because I have a raffle prize or several raffle prizes to give out to you guys. So we'll do that at the very end. But if you guys have any tips and tricks about finding information that's pertinent to your patient from the charting for their brain, since they do have a limited time in the morning and don't have those 3 hours or whatever the day before that we might have given in the past, that you can remember. I know every charting is a little bit different. So if you guys could touch on that. I know for me, I looked into the health and history first and found out what the first thing the doctor said and what they perhaps were diagnosed with right in the beginning, and doing a little bit of research on that if I didn't already know about it. And then looking at the latest labs and vital signs. But also taking note of what the labs and vital signs were when they first came on the floor and recognizing any trend or any shift that has happened. It can be difficult to do and recognize right off the bat. That's something that takes time and practice. So do practice it, but no, it's not going to come right away. But noticing like, oh, while they're on the floor, their hemoglobin was 10 when they first came in, but now it's leaning on 8 and 7. And so that's something that, why is that? Are they having an obvious bleed, or do you think they might be bleeding into their abdomen? So things like that, noticing the trend, but not focusing too much on that of like going into every single lab result, just knowing like what's abnormal, what has changed a lot, how is that going to affect the medications, and that sort of thing. I use the brain. I think the brain was really helpful for me, just jotting down. I know it, like some people hated it, but it helped me kind of organize my brain. And so that kind of was helpful for me, and something that my professor taught me over time was looking at the change in labs and vital signs over time, because it might not look super out of the ordinary. It's still within normal range, but it's changed a lot since they first got here. I don't know if you guys have anything else to add to charting.
For me, it was the brain. The brain was like a little Bible to me that I would carry with me everywhere. And something that I learned on my own was that I would first look at the medications, write them down, and then I will look at their HMP, and then from there I would say, okay, so they have this diagnosis, and this is a reason why they're taking this medication. Or even try and do it the opposite way. Once I got like more experience, it's like, oh, so I see the medications. So I would kind of look at the medications and kind of determine, it's like, oh, like if this patient is taking this medication, then most likely they're having this. And then like I would go back to their HMP and say, yes, I was correct or I was incorrect. So that's one way that I would kind of test my knowledge on that.
So one thing that is very useful, and a lot of people don't utilize it at first, is the most recent doctor's progress note. It tells you what is going to happen to the patient, like if they're going to get discharged to a specialty nursing facility, they're going to go to rehab, they're going to go home with home health. It tells you those kind of things, and it also can tell you little things about the patient that you may not know, such as patient had pneumothorax in left lung, so they are in the left side of their chest, so they may not have a left lung, and you might like go and listen and be like, I don't know what I'm listening to, but I don't want to look like an idiot, so I'm just going to say heart sound or lung sounds present, and then they're like, hey, there's no left lung. So what did you really hear? So there's little hints in there that'll help you be able to maybe focus your physical assessment a little bit better, know more about the patient, know what the doctor's thoughts are, and it'll also have all of their past diagnoses, like current health problems like hypertension and how they're managing that, or diabetes, how they're managing that. So I always looked at the most recent doctor's note because that had a wealth of knowledge that most people didn't think to look at.
I don't want to get too off topic because I kind of zoned out in the middle of your question, Bianca, but I think I kind of know what was asked. One thing that I noticed as a new nurse, it's important to make sure, like, before you give medications, make sure you check their vitals. You know, you don't want their blood pressure to be low and you don't know, and then you give a blood pressure medication and then it drops it even more. So just because a med is due doesn't mean it's due. Like, make sure you know, are they okay? Like, are their vitals okay? Again, like, is their hemoglobin okay? Should I give this blood thinner? You know, make sure you kind of investigate a little bit before you go in there, because also your professor is going to be like, okay, what is this medication for? So if you don't know what you're giving, then what are you going to tell the patient? So just make sure that you do a little bit of research before you go into their room. So that way when you're explaining things, it's just easier on both parts.
And I'd like to expand on that. There have been times where a medication on the MAR, it says this medication's due at 9, but it's an every 6-hour medication. And thank goodness my clinical professor saw it, but my patient had gotten that medication within 6 hours. And so we couldn't give it yet. And so talking to my nurse is like, this medication's due, but I'm not comfortable giving it to the patient because the doctor's order is every 6 hours or whatever the time was. And so finding out that, you know, we have to change the MAR, and that's something that your nurse can do for the medication. So knowing the right dose, all their clients' rights that we talk about all the time, right dose, right time, route, all of that. So thank you all to my panel for coming and sharing your knowledge and experiences. It was super helpful. And I think it'll be super helpful. Again, this is being recorded and Sean is gonna post it on the website, so you guys will be able to either rewatch it or share it with any of your peers that weren't able to come, or if you came late in the meeting, you can check out our first answers. But we have a raffle, and I have some raffle prizes and winners. And so I'm going to announce them here, and I'm going to put in my email address into the chat box. If you could email me and we can coordinate when you'll pick up the raffle prize. So we're giving out a nursing clipboard. So if you guys don't have it yet, those are a lot of fun. It has good information on the back of it, a little cheat sheet. And so our nursing clipboard winner is Amanda Franklin. And we're giving out a pair of clinical scissors, which is very important. If you ever have to give a medication that you need to cut open, or if for whatever reason you can't open your IV bag because you slipped or whatever, scissors, keep them on hand. Our winner for the scissors is Kathleen O'Brien. And then we're also giving out hand sanitizer, very important these days, is going to Sierra Haley, and we have lots of scrubs to give away, and our winner for scrubs is Andrew Davis. And so I'm putting in my email there, so if you guys could email me, and we'll coordinate when to pick them up, probably on Fridays, since I think that's when you guys have your clinicals, and I'm also at the nursing school on Fridays as well, so we can coordinate that. So congratulations to our raffle winners. Thanks again to our panel. I really appreciate you guys so very much. And if you guys